Hi, welcome to antineoplastic drugs, or also known as chemotherapy for cancer. This is going to kind of be a review from what you learned in 112, fundamentals of cancer therapy, identify prototypes, identify action, adverse effect, and limiting factors of those prototypes. So first off, we want to know the goal with chemotherapy is to kill all the cancer cells, all of them. And how do we do this? Because if one is left, it can repopulate and multiply. So we give chemotherapeutic agents, we give radiation. Chemo is a piece of the treatment. They might need surgery. This picture on the timeline is showing chemo agents kind of back to 1900. It talks about, over time how we've seen improvement, and several agents are old, but we're still using them. In 1900, there was the animal models. Then if you go up to around 1943, they had the nitrogen mustard drug, which is still being used today. Let's see, in 1948, methotrexate, 60 years old, we're still using methotrexate. And then 1959, some anti-tumor antibiotics. There's a lot of older agents in there that are still being used. When they formulate them, they look at what it takes to kill cancer and not normal cells. In contrast, antibiotics have selective toxicity, and they won't damage normal human cells. But cancer chemotherapy is not selective, and it can kill the normal cells. We know that. So that's a limiting factor in giving it as much as the body can take. Then you allow the body to recover some of those good healthy cells again, and we do intermittent therapy. You try to cater it towards the type of cancer cells, the cell type of growth rate that cancer cells have. It's designed to attack cancer cells more than normal cells now, as they're formulating them, trying to get agents that work more selectively. But for this lecture, we know that they don't have selective toxicity like antibiotics do. Okay, we're going to talk about routes just a little bit. We know that just along with any drugs, they have similar routes. Oral is most convenient. Anytime an oral agent is given, it's important to teach the safe handling. That's why the yellow, warning sign is there. Most nurses who give this kind of medication, all nurses are going to have special training to administer these drugs, because they found over time that people without cancer causing cancer agents can get cancer because of handling these kind of drugs. We need to provide safety teaching to who should be touching them and who they shouldn't be touching them, how they handle the drug. IV is the most common form. They come to outpatient infusion center and they're going to get their dose IV. But they can also get intrathecal in the subarachnoid space. They might need a reservoir, a pump, or a lumbar puncture with each of those. Direct route to the CSF, direct to the brain, avoids the blood barrier. So that's for therapy in the CNS cancers. Intraarterially, the advantage is you're giving it directly to the artery, which arteries feed tumors and cells, so it's going to directly go to the cancer or the tumor. Arterially, you get a higher concentration right there. The downside is you got to have this implantable pump again, or line to give it that way. Intraperitoneal, it's right to the cancer if it's in the peritoneal space. Better local action, a higher concentration right there in the space where it might be needed. Again, you got to observe all safety precautions while handling blood and body fluids with these kind of people who are getting these agents. Okay, the first one we're going to talk about is cyclophosphamide, or Cytoxan. It's an alkylating agent. It's a nitrogen mustard. It's a prodrug. It's old kind of drug, but it's still used. It's a broad spectrum chemo agent against a lot of cancers, but then again, it's not as effective specifically. It's used alongside other drugs for a more specific killing effect against cancer. How it works, it's a prodrug. You give it, and once it's metabolized, it becomes activated to phosphoramide mustard. So what that does is it alters the shape of the DNA. It ties the two different guanine bases together, and then the cell can't replicate because the message is wrong now, and then it dies. It's cell cycle non-specific, and we'll talk about that a little more. It doesn't matter what place in replication the cells are at. It acts anyway, so it doesn't matter when. The adverse effects, of course, anorexia, nausea, vomiting, weight loss. We know about these. We're going to think about pre-medicating with Zofran. We know about the nausea and vomiting. There might be mouth sores. There might be alopecia or hair loss. Cardiotoxicity and pulmonary fibrosis are two big ones to watch out. The cardiac issues happen with higher doses. And then a limiting factor is going to be your bone marrow suppression or myelosuppression. We know that that's where the red blood cells, white blood cells, and platelets are made. The nadir is 9 to 14 days. That's where it's at the lowest point of your cell production for the red blood cells, white blood cells, platelets from the bone marrow. That's going to limit the dosage. If you get to that nadir sooner, you might have to stop your chemo ahead of time. But the point being here that their CBC is going to need to be checked often, and then checked again. So after they reach the nadir, then those counts will come back up. So then after the 9 to 14 days and you have recovery, then a couple weeks, 3 weeks down the road, maybe another dose of chemotherapy. So for drug metabolism, there's lots of things that can happen. It can increase or decrease metabolism of drugs. We're not going to get into the specifics of that because it's used as an immunosuppressant. This makes sense for treating rheumatoid arthritis because we know that you want less immune actions happening with that. That might be wrong. This drug might be used for people who are having rheumatoid arthritis as well, but we're going to go on to methotrexate now. Methotrexate, it's also a DMARD. If you remember, DMARD is disease-modifying arthritis. I can't even remember what the DMARD stands for myself. Disease-modifying anti-rheumatic drug, or it's an immunosuppressant. It's an antimetabolite. It's a folic acid analog. Let's see. So it interferes with cell metabolism and division because as a folic acid analog, it tricks the cells into thinking that that's their folic acid that they need to grow with. And so the cells pick up this fake folic acid, and it interferes with the conversion to folinic acid or activated folic acid. So their cell division doesn't work, so the cells die because they can't replicate. One thing is that we administer leucovorin to help save the normal cells, this synthetic folic acid, so that the healthy cells don't take that up, just the cancer cells. So it goes to the healthy cells, and it's usually you should expect to see it used with methotrexate. Some adverse effects with methotrexate are nausea and vomiting, hepatotoxicity, anorexia, interstitial pneumonitis, and abortion. So it's a category X drug. Should not be for anybody getting pregnant or wanting to get pregnant. A limiting factor is myelosuppression, also pulmonary toxicity. If the cell counts are too low at the point they'll stop it, or if pulmonary problems start to develop, then they'll stop that treatment as well. And this picture was just there to help you realize how the folic acid is used down the line in the end to make this DNA replication or to help the cell to replicate. And so the methotrexate is blocking it way up high there at the dehydrofolate reductase step. So methotrexate kills cancer cells because it disrupts folic acid pathways and slows the growth of the cancer cells. Okay, doxorubicin or adriamycin, it sounds like an antibiotic. It's an anti-tumor antibiotic similar to alkylating agents. It binds to DNA and inhibits synthesis and cell division, so it kills the cell. It is limited by myelosuppression and cardiotoxicity. The nadir is about 7 days. It's a severe vesicant, So this is one, it's given by injection only, so they have a line in, or it might be to a body cavity. Interstitially, it will be severe damage to the tissue. So if you see this reaction happening, you need to stop the IV immediately, and this is the drug that you put ice to the area to slow the absorption and to minimize the tissue damage. It's best to not have it happen, but you need to know what to do. So they would usually have a port or a PICC line for this. It's a vesicant with a number of chemo agents. You need to know what to do with the infiltration. This one specifically, you need to put ice on. There's another one we'll get to where you put warm to it. So I'll talk about that coming up. But some other adverse effects are nausea, vomiting, mucositis, hepatotoxicity, cardiotoxicity. So tachycardia or bradycardia, heart failure. It can be seen early in or later, even months to years after treatment. Also, this is one with the red coloration of tears and urine, to be teaching the patient this information about that so that they know it's going to look weird, it's not going to hurt them, it might stain some stuff. It's injection only. The extended release form is a Doxil, which is got liposomal carriers, and that extends the half-life. So less frequent dosing and a longer action with that kind of medication. All right, so hormones and hormone antagonists. This is the part where we know that breast and prostate cancer are fed by some hormones. So if we can find a way to block the hormones effect, we can help with that. The one we're going to talk about, tamoxifen, or Nolvadex or Soltamox, is an estrogen receptor blocker. So it's the most commonly used treatment, and a prophylactically used also estrogen receptor blocker. Also, you might remember SERM for selective estrogen receptor modifier. It's selective, so that means it's an antagonist to estrogen receptors in the breast tissue, but it's an agonist for other estrogen receptors to other tissues like the bone. And we know estrogen helps us protect our bone strength, so you get the benefit for the bones, but the antagonist for breast tissue to block the nutrient supply to those cancer cells that feed on estrogen. Treatment is for palliative. It's not great at killing cancer. It's not a great cancer-killing agent, but it's not for aggressive cancer. It's for advanced, so palliative, and prophylaxis for those with high risk of developing breast cancer. Adverse effects are similar to anybody with a hormone imbalance. Nausea, vomiting, always with things, hot flashes, irregular menses, increased risk of endometrial cancer, and thromboembolic clots, like with contraceptives, oral contraceptives. With the endometrial cancer, there'll be the benefit-risk ratio that you have to look at. If the benefit outweighs the risk for developing, then they would use the drug. It's not as strong maybe for the prophylactic side. If you have a risk for developing endometrial cancer, that history is strong with you, you might not be getting this kind of medication because of that. And then I showed this picture just to show the estrogen receptor being blocked by the SERM, or in this case it would be the tamoxifen, so that the estrogen can't be feeding the tumor and its cell growth. All right, so some natural products. Let's see, vincristine is Oncoven. It's a common chemo drug. It's cell cycle specific to the M phase, so that it inhibits mitosis of cancer cells. So it disrupts the distribution from the parent cell to the daughter cell. So there's not a full set of directions going to those new daughter cells. It's limited by neurotoxicity. Got to look at cranial nerve palsies, so diplopia, double vision, vocal cord paralysis, peripheral neuropathy, decreased with reflexes. It's a strong neurotoxic agent, so you need to teach people to look for these adverse effects and notify their physician, because that would be some reason to stop taking this medication. Also, this is the other one that has bad extravasation, necrosis, damage to tissues. If you're giving it IV and it infiltrates, you need to stop the drug. This one, we're going to do warm compresses. It could increase the toxicity. Cold increases the toxicity. So remember with the other medication, we had to put ice on it. That was doxorubicin or adriamycin that has the bad interstitial tissue damage if it's infiltrated. And then this one, the vincristine or Oncovin, we're going to put warm compresses to it. That helps with the IV infiltrate. The hyaluronidase increases the dispersal of vincristine in the area, helps it get out of the interstitial space and into the bloodstream. It's not on the test. Just know that if there's an infiltration, they might give this drug as an antidote, that hyaluronidase. Let's see. There's something else about vincristine that I needed to say, but I can't remember what it was right now. Anyway, the last category is the biological response modifiers. There's let's see, these drugs are not directly cytotoxic, but what they're going to do is tell your immune system to get up and get working, stimulates our immune system, and it enhances our immune system. One is interferon alpha 2 or intron A. It is naturally released by our bodies in response to a virus. So it binds to the virus, it suppresses division, it enhances phagocytic cells so that they come over and destroy and eat the viral cells up. And it's used with cancer and antiviral agents. So rituximab or Rituxan is a monoclonal antibody. It's man-made, it binds to the cancer cells, and depending on the agent, it will kill or it will mark the cell for the immune system to catch it, to fight it and kill it. And it might be specific for breast cancer. So on this picture on the side, it's showing just what your normal body does in response to a virus. And you see that interferon is part of our cells, and it is released, and it does a couple of things. It tells uninfected cells to be aware of this virus and to destroy the RNA and reduce protein synthesis. It also tells the cells to undergo apoptosis, and it activates immune cells. So it does quite a few things, and this is our normal immune response. So when giving these drugs, let's see, you need to know that they might get flu-like symptoms because they're enhancing what your immune response normally does. All right, so in closing, there's a few things we've got to reinforce this safety factor. If you are interested in being an oncology nurse, you are going to get some kind of training, and you have to have this to make sure you're giving these drugs safely. There's certifications by national organizations. There's numerous agents. We only talked about a few here, but there's a lot of cancer agents. There's a lot of new drugs coming out. There's new research. A lot of agents used against specific types of cancer. They're zeroing in on ways to really specifically treat cancers that are specific to people. You know, like fingerprints, they take your own cells and figure out what you can do to kill that cancer yourself and help your own immune system kill that cancer. We will see adverse effects on patients who are admitted in the hospital that are on chemo with uncontrolled nausea and vomiting. They're going to need rehydration. If they're severely immunosuppressed, they're going to be brought in and put on protective isolation. There's a lot of teaching that goes with that as far as our actions and actions of family and friends who may be visiting that person. So we just need to be aware of these things because you'll see these patients in the hospital, not that you're giving the chemo, but that you see them with their adverse effects of receiving chemo. So that wraps up this part, and we'll go on to antivirals next. Thank you.